So I think we could get started with this session of the ethics rounds today. Let me share my screen and bring up the PowerPoint. So again, this is the ethics round, September 17th, 2021. The CMA code is 15433. So I want to remind everyone that these ethics rounds are brought to you by the Ethical Advisory Committee, and this slide reminds you that we're available 24/7, and our contact number is listed on this slide. You could call me on my cell phone, 443-562-5143, or place an order in Epic, or you could use Tiger Connect, and you can either access UMMC Ethics or access me, Henry Silverman. Okay, so let me remind everyone that this session is accredited for CME credit, and we have available one category 1 credit. To obtain credit, you register at this website here, and again, the CME code is 15431. So the objectives of the CME activity is that participants should be able to, after the completion of this activity, to discuss ethical dilemmas in clinical practice, and also learn how to use an ethical framework for solving ethical dilemmas. So with all that, let me start with the first case. Can a mother provide consent for an abortion on her mentally challenged daughter? So we got an ethics consult from the Women's Clinic, and a person who adopted the patient at an early age arrives from North Carolina after having reached out to the center seeking an abortion for her 23-year-old mentally challenged daughter, who is now about 8 to 10 weeks pregnant. The daughter has duplication of chromosomes 15 and 16, and previous psychological assessment performed several years ago was significant for mental developmental delay. So the mom is the court-appointed guardian from the North Carolina court system. The mom had reached out to University of North Carolina at Chapel Hill, but the ethics board turned down the request for the abortion. Having said all that, there is allegedly a concern about a high-risk pregnancy due to aortic stenosis. So what further information is needed in order to properly analyze this case? So go to menti.com and write down your results, and I'll give you a few minutes in order to do that. Okay, access the website. And so let's see what kind of information is needed further. So one person said, what is the degree of delay? Mental cognitive assessment. Does the mother have the ability to make other medical decisions for her daughter? That's a good question. How significant is the degree of mental developmental delay? Can the patient appreciate her condition fully adequately? Good comment. Cardiology evaluation. Okay. What does the daughter say about the pregnancy? Does being the adoptive mother give her the medical POA? Does the daughter want to keep the baby? Interested to see if the pregnancy was a consequence of rape. These are all good questions. Again, is the mom the POA? Does the daughter have the abilities for activities of daily living? And what does the patient make other medical decisions for herself? So here's here's a list of further information, and I think you all said everything that's on the list. Results of psychological assessment, results of cardiac assessment, who will care for the baby, the risk of genetic inheritance, the extent of the guardian's authority, and the desires of the daughter. A psychological assessment, a formal one, was done in 2019, and the impression was developmental issues include autism, borderline IQ 74, poor social judgment, inability to associate cause and effect, personality disorder, oppositional defiance disorder, understanding of discourse is severely flawed, very naive, and has difficulty understanding danger. Several years ago, a student at her previous school took her in the woods to talk to her, but proceeded to rape her for 4 hours. Concerning genetics, we are dealing with a duplication of chromosomes 15, 16, probably inherited by her biological mother and is shared by each of her 4 siblings. Should the daughter have children in the future, each of her children would be at a significantly increased risk, 50%, to inherit at least one of these duplications. Concerning cardiac workup, an echo was performed in 2019, and it showed trivial thickening of the right aortic sinus valve cusp with normal valve function, normal LV size and function. The impression was a mildly abnormal aortic valve, so essentially this is not considered a high-risk pregnancy. Now, the authority of the guardian, according to the Guardian papers from North Carolina, it says the guardian of the person is fully authorized and entitled under the laws of North Carolina to have the custody, care, and control of the ward. But it does not specifically say that this authority does extend to abortion. More about that in a few minutes. And now, the desires of the daughter is that she's happy to be pregnant, and she had removed her IRD several months ago. Not sure why she did that. What to do now? Essentially, how does one balance autonomy, beneficence, and non-maleficence? So go to menti.com and vote. Should an abortion be performed on the daughter with all the information we have right now? So go to menti.com and vote. And I'll give you a few minutes for that voting. And let's look at the results. Right, so these are the results. Should an abortion be performed? I think a significant majority is saying no. 5 says yes, 19 says no, and 6 says still not sure. So let's review some more background information from the literature about this issue in mentally challenged individuals. So this slide shows a list of some newspaper headings, if you want to call that literature. Here we have Fight for Life, mentally ill woman forced to have abortion by judge who said she treated like a nice doll, but another court system said she can keep her baby after the appeal ruling. Here we have forced abortion decision overturned in case of 22 weeks pregnant mentally ill woman. And we have this article here, protecting the right to choose of women who are incompetent. Now, this is an interesting article from the Hastings Center report. When a mentally ill woman refuses abortion, this slide shows some conclusions from that Hastings Center article. It starts off by saying a legal determination of the patient's competence to dissent or consent to an abortion is crucial. I think everyone will agree with that. This might be provided through a court decision or based on psychiatric evaluation. If a patient has a basic understanding of what abortion entails and what continuation of her pregnancy entails, that cognitive requirement is satisfied. Essentially, one must match a right with a responsibility. Exclusive emphasis on autonomy undercuts the principles of beneficence and non-maleficence, which remains applicable in such cases. The right to procreate should be limited by the capacity to take responsibility for the result. The patient's right to bring forth a child ends where my duty to care for her child begins. So that article is, shall we say, more of advocating for a strict assessment of competency should determine whether an abortion should occur. Now, having said that, now it's instructive to review the statements of the appeals court that overturned a forced abortion. The appeals court decision found that the lower court based its decision predominantly on the medical evidence. The appeals court believed that medical evidence without more did not in it of itself convincingly demonstrate the need for such a profound intervention, meaning the abortion. The appeals court also felt the lower court clearly gave inadequate weight to the non-medical factors in this case. For example, the pregnant woman's wishes and feelings. There is a clear overall view of a young woman who wishes to have a baby. And I find it instructive. Someone on the chat said, wouldn't it be traumatic to take that baby away? Now, regarding feelings and emotions, one person on the chat said, wouldn't it be traumatic to take that baby away from her for adoption? I think the answer is probably yes, but to be even more specific, the literature talks about severe psychological effects with mentally challenged individuals who undergo a forced abortion. So I think a lot to say about psychological effects. So let's see what Maryland law says about the reproductive rights in mentally challenged people. It says, effective adjudication of disability and appointment of guardian. It says, appointment of a guardian is not evidence of incompetency of the disabled person and does not modify any civil right of the disabled person unless the court orders. And so essentially, this statement affirms a primacy of reproductive rights and also states that the court should decide when this right could be taken away. In terms of follow-up, the guardian was told that she would need to file a petition to have a North Carolina guardianship transferred to Maryland, and then petition the court to grant her the authority to allow an abortion. Essentially, when she heard that, the guardian decided not to pursue court proceedings. And we don't have any other follow-up. So let's continue on with the second case. Can a patient refuse further dialysis? So the patient is an 80-year-old female with a history of hypertension, Raynaud's, GERD, HLD, who presented to the emergency department with progressive shortness of breath and bilateral leg swelling, despite the use of outpatient Lasix, with symptoms beginning 4 weeks previously. She also reported a band-like pressure parathesia to her left forearm. She was admitted for workup of a hypertension, which is in the 70s and 80s. At baseline, she lives independently and very active per her daughter-in-law. So a hospital cost, vascular surgery, and cardiology were consulted to evaluate arterial perfusion in the setting of low blood pressure. During this time, she developed worsening chest pain, and an EKG was suggestive of a STEMI. Per chart review, the patient also had episodes of amaurosis fugax in each eye over the past few weeks. She therefore received duplexes of her upper extremity, which demonstrated bilateral upper extremity occlusive disease. MRI showed multifocal possible embolic infarcts, for which she was started on heparin. Patient was then transferred to University of Maryland Medical Center for further evaluation of a symptomatic arch disease and high risk for a stroke. The patient was admitted to the IMC for further management and monitoring. Patient underwent bilateral sternotomy, aortic carotid bypass, post-op significant for profound acidosis and acute kidney injury, for which CRT was started. She has since been transitioned to intermittent hemodialysis, no further episodes of hypertension, and she is ready to be transitioned to the IMC. Over the past weekend, the family comes in on Monday and states that the patient no longer wants dialysis, and they are very insistent that she should not receive any more dialysis. So, what to do now? All right, go to menti.com and just give me your thoughts. Write down some of your thoughts, okay? I'll give you a few more minutes for that. Okay, so let's see what we're all thinking about. All right, talk to the patient. Respect patient autonomy if mentally capable. Talk to the patient and see if she knows the risk benefits, capacity evaluation, prognosis of the underlying condition. Make sure the patient is well informed. Respect patient risk. Assess capacity. So essentially, you're all correct. It all boils down to what is the extent of her decision-making capacity. So I saw the patient in the presence of her son and daughter-in-law. The patient was awake and alert and able to hold a normal conversation discussing her desires and wishes. Although she says she wants to go home, she quite frankly said she is tired of dialysis, gets very fatigued, and essentially no longer wants it. And she wants it stopped. I asked her, does she realize that, well, I says most likely die, but I said, will die without dialysis. And she said yes, and she is at peace with this decision. So let's do a quick poll on the chat box. Should the patient's request be permitted? And just write down on the chat box what you think. And one person said yes, no, yes, 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 honor her wish, yes, 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 honor her wishes, yes. She has a right to decide. One person said no. One person said, well, post-cardiac surgery often leads to depression. Has she been evaluated by psych? Okay, so I think a lot of people are saying that her request should be permitted. When assessing capacity, as I have said before, one uses the sliding scale determination of capacity. And that means the more a decision has adverse implications for a patient's medical welfare, the more certain we would want to be of that person's decision-making capacity. However, the focus should not only be on medical welfare. Any decision to discontinue life support, while not supportive, will surely not be supportive of her medical welfare. One should also consider whether it's supportive of her other needs that respect her to lead a self-determining life. So basically, with this sliding scale, we really want to be certain whether that decision is respecting her to lead a self-determining life. And after assessing her capacity, a conclusion was made that she has capacity to refuse further treatments. And the outcome was the patient was made comfort care measures only, dialysis were discontinued, and she was transferred home, and she died peacefully 2 days later. Okay, thank you very much for your comments. Okay, so let's go to our third case. Should the patient receive ivermectin at the request of his mother? So we have a 25-year-old man who tested positive for COVID-19, non-vaccinated, presented to an outside hospital with pneumonia. Patient was started on dexamethasone and remdesivir and also received Toxi. Patient was transferred to the ICU requiring high-flow nasal cannula and FiO2 100%. Patient was intubated due to worsening hypoxemia. Was found to have diffuse pneumomediastinum and subcutaneous emphysema. She was transferred to University of Maryland for VV ECMO evaluation. Patient arrived on high levels of PEEP and FiO2 with SpO2 in the low to mid 90% range. A decision was made to cannulate him for VV ECMO. Hospital cost was significant for the patient continued to do poorly. Subsequently, the mother requested that the patient receive ivermectin. Initially, the hospital refused, but the mother then had her lawyer call in, a lawyer from New York, call in, threatening to sue. The case was reviewed by treating physicians, hospital counsel, and the ethics service. So why don't you write down in the chat box arguments for and against administration for ivermectin. Let me give you a few minutes to write your thoughts in the chat box. Okay, let me review some comments. Comments for administration. One person said, you could argue that it should be given to allow a more peaceful relation with the mother, and it will likely not worsen his prognosis, which is grave anyway. Another person said, the human version, not the veterinary version, has a very good safety profile, even if not definitively proven effective. It is not a toxic drug at therapeutic dose like chemotherapy. Sometimes doctors make allowances if they feel it is not harmful for patients' wishes. Well, for patients' wishes. So some arguments for against administration. One person said, on the other hand, giving it will pave the way for other quack therapies to prevail, setting a precedent. Another person said, physicians should not, and I think cannot be compelled to give a dangerous and not approved therapy. Is it possible to allow the mom to give it? Well, I don't think the hospital would allow that to happen. Another person said, do we have to now give every medicine that a patient requests? Another person said, who is licensed to practice medicine and care for the patient? Okay, so some differences of opinions here. So there was a family meeting. The primary purpose of the meeting was to review and sign the consent form regarding ivermectin dosing and administration, which the family was aware of. Briefly discuss the risks of the drug, although low, why the patient might be at higher risk due to COVID and critical illness. Our current resources only allow for a 5-day course as listed in this contract. Patient mother reviewed the contract and signed the forms willingly. She was very thankful and appreciative of our consideration of the drug and final decision. So some statements from the literature, newspapers, an article from the Wall Street Journal, which I must admit, a lot of times I get up to date with medicine from the Wall Street Journal, but I read it very carefully. This article says, why is the FDA attacking a safe, effective drug? This article goes on to say, in 115 patients with COVID-19 who received a single dose of ivermectin, none developed pneumonia or cardiovascular complications, while 11.4% of those in the control group did. Fewer ivermectin patients developed respiratory distress, fewer required oxygen. Despite the FDA claims, ivermectin is safe at approved doses. Out of 4 billion doses administered since 1998, there have been only 28 cases of serious neurological adverse effects, according to an article published this year in the American Journal of Therapeutics. If the FDA were driven by science and evidence, it would give an emergency use authorization for ivermectin for COVID-19. Instead, the FDA asserts without evidence that ivermectin is dangerous. Well, a few days later, these writers wrote in the Wall Street Journal, writers missed ivermectin study retraction. We have egg on our faces. We, the authors of this previous article, have egg on our faces, relying on the summary of studies published in the American Journal of Therapeutics. We quoted the results from a study of 200 healthcare workers. After our article was published, we learned that this study by this investigator from Ben-Ha University in Egypt has recently been retracted due to serious charges of data manipulation. They conclude we retract the part of our article that relied on the data from this study, but the broader point stands. There's strong evidence of ivermectin's efficacy in treating COVID-19. Well, the AMA and the WHO and the CDC and other groups warn against ivermectin use for COVID-19. Essentially, people are using the veterinary formulation and essentially overdosing, giving them themselves an overdose of ivermectin, and essentially the literature, the previous literature on efficacy of ivermectin in COVID-19 is still lacking formal study. One concern that I had about giving ivermectin is that this would lead non-vaccinated patients to think they now have an oral drug to treat their illness and remain unvaccinated. Also, I think having University of Maryland, a well-known research institution, given ivermectin may give the stamp of approval for this drug. Other statements in the news: Louisville woman's demand for Norton Hospital to treat husband battling COVID with ivermectin denied by the judge. Now another judge orders a Ohio hospital to treat COVID patient with ivermectin, but an appeals ruling, an Ohio judge reverses an earlier order forcing a hospital to administer ivermectin. This legal opinion from this second court states, after considering all the evidence presented in this case, there can be no doubt that the medical and scientific communities do not support the use of ivermectin as a treatment for COVID-19. Further statements from this legal opinion is shown in this slide. Plaintiff has not shown a strong or substantial likelihood of success on the merits. The plaintiff has not shown irreparable injury will occur without the medication, and the public interest would not be served. More specifically, while this court is sympathetic to the plaintiff and understands the idea of wanting to do anything to help her loved one, public policy should not and does not support allowing a physician to try any type of treatment. So as you probably know, the issue of ivermectin is very much talked about in the literature and in the news. And I think most of the reports are showing a grave concern with individuals taking large doses of ivermectin, when instead there really should be a very formal randomized control study. So this patient was non-vaccinated. So let me end by asking, should vaccination status count when medical care must be rationed? This was an article written in the Washington Post, another place where I get my medical news. And so let me, why don't you all write in the chat box, should vaccination status count when one needs to ration medical care? So let me see what you all writing. One person said, not vaccination status, but ration by acuity. Save those who can reasonably be saved. I see a lot of no's. As one person said, as much as we like to punish the unvaccinated, it must be no. Humans don't decide, sinners. So essentially, subtitle of this previous article I showed, ICUs are overflowing with COVID patients, but triage is not about denying urgent treatment to the sinners. So let me state a few final thoughts about this issue. Is it defensible to deny urgently needed health care to punish a patient for not making healthy choices? Well, we do not deny care to other patients who make unhealthy choices. Well, one could say, but what about when resources are scarce? Like, what about the person in liver failure who is denied a liver transplant? Well, it's not exactly analogous situation in the sense essentially patients in liver failure who are denied a liver transplant, the reasons are based on poor social support and really hard evidence that the patient is most likely will not stop drinking. Though having said that, I know some hospitals have this 6-month abstinence rule, but studies have shown patients with or without abstinence have similar outcomes. But without getting into the nitty-gritty of liver transplant, maybe at a future ethics rounds, even when resources are scarce, the conceived wisdom is not to punish who we think are sinners. Those who decline to be vaccinated or comply with non-pharmaceutical requirements should expect restrictions on school attendance, travel, employment, and even access to indoor spaces, both public and private. This should not apply to medical care. Essentially, trust in the medical profession is at stake. Well, thank you for your thoughts, and we'll see you next time at our next edition of the ethics round. So have a good day. Bye now.